Okay, good morning. Welcome to the Aspire webinar series, and this is the Thin Endometrium webinar. I'm Dr. Virgilio Novero from the Philippines, and I'll be moderating this webinar. Implantation remains as the rate-limiting step in ART, and the thin endometrium is one of the challenges in this particular topic. When it does happen, most correlate it with a significantly decreased implantation and pregnancy rate. And the available methods to try to correct this problem has not been made clear on what works and what doesn't. We have 6 renowned speakers from various cities all over Asia, all experts who have prepared lectures in various aspects of this problem of the thin endometrium. I hope you have listened to their excellent recorded lectures in the Aspire website. Today, we shall hold the live Q&A, and we shall give the audience a chance to ask your questions to these experts. But before we get to that, let us have a quick recap of these 6 lectures. We shall ask our speakers to give a summary of their talk. But before we do that, I just like to remind the participants you can put in your questions in the Q&A box in your Zoom platform. Okay, so let's start with a recap. I'd first like to call on Associate Professor Louise Hall on the topic, how thin is too thin and when?
Thank you so much, Virgilio, for asking me to speak today. And my topic was how thin is too thin and when? And it really is explaining how to measure the endometrium in a longitudinal axis at the thickest part. And the tricky part with the thin endometrium is that many different groups have used different cutoffs, and for various reasons. The cutoffs mainly used are 7 millimeters, which affects about 2.4% of the people we see. When you go thinner than that, it's less than 1% of people will have a 6 millimeter endometrium or thinner. And when you cut off at 8 millimeters, which is the 95% centile, it's about 5% of people will have a thinner endometrium than that. So it's actually a very small proportion of the people we treat in fertility, but there are some effects of the thin endometrium. The first thing is that it's actually not predictive of pregnancy. So the ROC curve, if we were going to use it, should be very much up in the top of the left-hand corner here if it was highly predictive. If we could say, if you have a thick endometrium, you'll get pregnant. If you have a thin endometrium, you won't. So it doesn't predict pregnancy, and other factors are much more predictive of pregnancy. For example, the quality of the embryo. Additionally, in terms of ongoing pregnancies and live birth, there's a lower chance, but it doesn't reach significance. So it's not significantly significant, it's just a trend that you've got a lower chance. However, when you look at actual clinical pregnancies rather than live birth, it becomes significant in retrospective reviews. There's also been a very large study in China that demonstrates that the thicker the endometrium, the higher your chance of pregnancy. But even women with an endometrium under 8 millimeters will have about a 24% chance of pregnancy, compared to when it's 11, it'll be about 53%. So there seems to be an increased chance, but you still have a reasonable chance of pregnancy with a thin endometrium. In that particular study with all those women, they also showed a decrease in the rate of ectopic pregnancy or miscarriage if you had a thicker endometrium. So a thin endometrium was associated with a higher chance of miscarriage and ectopics. But again, that's one study. It's a very large study. It's retrospective, and we really need more information, both on the etiology, which the other speakers are going to talk about, and how to know whether to transfer an embryo or not, and which treatments to use if the lining's thin, and do they work? And there's a lot more information that we need to know to work that through. That's it.
All right. Thank you, Louise. I'd like to call now on Professor Gendie Lash for her talk on causes and pathogenesis of thin endometrium.
I'd also like to thank the organisers for inviting me to be part of this really interesting topic. So really the causes can be broken down into two main areas. Physical causes, so where there is fibroids, Astroman Syndrome, previous caesarean section scars, or some trauma to the endometrium, and also hormonal causes, so extended use of contraceptives but very long extended use of contraceptives may impact the endometrium for years to come. We were discussing this before we came on air, the effect of clomiphene citrate, which may actually just be within the cycle of time, and there'd be very little hangover for that. There's also some evidence that infection and in particular tuberculosis, which in some countries is not very common anymore, but in others still common, can have an impact on the endometrium. While I was researching this topic for this webinar, it became very clear that while there's been a lot of work on how we might fix the thin endometrium, we don't actually really understand how those causes cause the thin endometrium. And we don't understand the science and the underlying reason for pathogenesis and why implantation in the thin endometrium may be impaired. So one of the major aspects around this is likely that that the makeup of the endometrium is imbalanced. So you have an imbalance in the numbers of leukocytes, which are absolutely required for the establishment of a successful pregnancy. They're not just there as infection fighters. They have, in particular, the uterine natural killer cells and macrophages have roles in tissue remodeling, regulation of trophoblast invasion, the alterations in the spiral arteries that are required to maintain and establish a pregnancy. Also, a diminished glandular network, so nutrition is off, and because the endometrium is thinner, you're much closer to the larger, wider arteries in the myometrium, and these can cause a hyperoxic environment, which the embryo does not particularly like. So from a scientist's point of view, we actually need to understand why a thin endometrium is bad much more before we can start to really developing useful, meaningful therapeutics for those women who experience this ongoing problem. So thank you.
Thank you, Gendie. Now I'd like to call on Professor Tin-Chiu Li of Hong Kong to give his recap on surgical treatment for thin endometrium. Professor Li.
Thank you so much, Joy. While my talk is on the surgical aspects of the thin endometrium, I want to highlight that not all cases of thin endometrium are amenable to surgery. However, thin endometrium secondary to the presence of intrauterine adhesions may be amenable to surgery. The preoperative assessment include a 3D ultrasound, which is better than that of a conventional 2D ultrasound in assessment of intrauterine adhesions, especially the irregular shadows, presence of a small amount of fluid. As far as surgical techniques are concerned, I think it will be good to use different techniques for different types and location of adhesions. We cover the several different types of methods, including the cold steel, the scissors, the hot wire, that is the diathermy, the balloon, and also the invisible knife, which is hydrotherapy. And among all these four methods, ultrasound guidance is very important. As far as postoperative adjuvant to reduce recurrence is concerned, we ought to consider using second look hysteroscopy and also balloon therapy. There are a number of other adjuvants like estrogens, like the gel, and other methods like the coil. They are not as evidence-based, and there is some controversies as far as their efficacies are concerned. Primary prevention is very important. We ought to avoid curettage of the gravid uterus, use medical methods whenever possible. But if surgery is necessary, then we have to be gentle. We don't want to scrape the endometrium too hard. Very gentle surgery and the precision surgery, either ultrasound guided or guided by the hysteroscopy. And finally, I would suggest that most cases of adhesion nowadays may be managed in the outpatient department without the need of general anesthesia, other than the very severe cases. And with that, hopefully, we can simplify the treatment modality for our patient with intrauterine adhesions. Thank you so much.
Thank you, TC. Now we go to our fourth topic on the hormonal treatment for thin endometrium. I'd like to call on Dr. Christos Venetis from Australia.
Yes, thank you, Virgilio, and I would like also to take this opportunity to thank the Scientific Committee of Aspire for inviting me. I was tasked with discussing hormonal treatment of thin endometrium, and probably I understand that this is a very basic concept, but at the same time, it's very commonly something that we neglect. We always think about exotic treatments that we will discuss later, and there are some excellent presentations on. But we're not really focusing on what we can do hormonally. And obviously by hormonally, we mean predominantly estrogen. Why? Because we do know that estradiol and estrogen in general are what drives endometrial growth and proliferation. And during my presentation, I cover all these aspects, but if I were just to summarize, I would say that natural estradiol, oral estradiol with doses up to 16 milligrams per day have been trialed and have been suggested to be safe. Obviously, these are not huge trials, and I'm happy to discuss them further. And the duration of up to 9 weeks has been proposed in certain cases where we need to prolong this treatment. Needless to say that in all these cases, we have to remain vigilant in terms of the risk of thromboembolic phenomena in cardiovascular disease, and also the risk of hyperplasia or dysplasia coming and breakthrough bleeding coming from the lining. Alternatively, vaginal alternative routes of estrogen administration is vaginal and transdermal, and they have one huge benefit, and that's that it can bypass essentially the liver metabolism of the oral estrogen, and that is why they might be particularly advantageous in certain cases. However, there are studies out there, some of them supporting that they might actually be beneficial, but there's no clear benefit, and certainly randomized clinical trials are not there to back their superior efficacy. There are also other hormonal treatments that have been trialed. Tamoxifen is, as you know, a selective estrogen receptor modulator, which is one of the few that has a proliferative effect at the lining level, and that has been trialed. ACG injection, mid-luteal GnRH agonist, and growth hormone. These are all hormonal interventions that have been trialed, but they're backed up by mainly very small studies, and in most cases, we do not have enough evidence to suggest that they could be beneficial. They're just providing some hints that some of them might be beneficial, and we need to keep researching. Finally, I think that my main message is, despite the fact that thin endometrium is an important problem for some of our patients, I think that the studies that we have performed so far are not the kind of studies that will allow us to confidently look at them and discuss with them what would be, the best protocol that would give them a higher chance of having a thicker endometrium and therefore a higher chance for pregnancy.
Okay, thank you, Christos. Thank you, Christos. And And I would like to hear the recap on the innovations of innovative treatments in thin endometrium. May I call on Dr. Madhuri Patil from Bangalore?
We know that thin endometrium is basically associated with decreased implantation rates as well as increase in miscarriage rates. And we also know that the treatment is basically challenging. So the aim of our treatment basically is to build up or increase the E2 levels or increase the delivery of the E2 to the target tissue. And this can be done by opening of the blood vessels. And this is how the adjuvants, what I'm going to talk on and I have spoken on, basically act. And this then will result in increased utilization of the estradiol to the target tissue and also will have its effect. So though we can see in this that none of the medical treatments what I have spoken about do have any evidence because none of them is showing agreed. And we can see GCF, the nitroglycerin patches, vitamin E, and I think they really do not have any beneficial effect and there's no evidence. But there is some evidence for using HCG as well as sildenafil. And what I feel is I think sildenafil is more patient friendly because basically it can just be used vaginally where we give it in a dose of 25 milligrams, either 8 hourly or we give it 6 hourly. And it has shown to have improved the endometrial thickness in about 92% of the patients, and there is increase in the pregnancy rate by about 50% in this group. But yet the evidence is controversial. There are a few papers which say that it works, whereas the others say that it does not work. And we need to have several randomized studies basically before we say that there is evidence for using sildenafil for increasing the endometrial thickness. But before that, it's very important that we need to rule out what exactly the cause is for the thin endometrium. The other drug probably which is promising is HCG, which can either be used subcutaneously. It can be given for about 6 to 7 days before the embryo transfer, and the other option is giving intrauterine HCG. Of all these, I've basically tried only HCG in a couple of patients where I've used it intrauterine, and I found that though there was minimal increase in the thickness, but it's not resulted in pregnancies. I've also used sildenafil in quite a number of patients, and in my experience, the endometrial thickness does increase, but it does not get converted into pregnancies. And if at all we have a clinical pregnancy, the live birth rate has really not increased. So I feel that probably there is no definite treatment as yet that has been established, and there is minimal evidence to support any of the specific protocols or adjuvants which are available and which increase the pregnancy rates. And I think case customization remains the key till we have a lot of RCTs which are there and we have evidence for using any of these modalities for treatment of thin endometrium. And so I think every patient should be treated as a separate entity, and we need to look at what works for them and not have one size fits all protocol wherein probably if there's a thin endometrium, you give this and it's going to work. Thank you.
Thank you, Madhuri. Finally, we go to the last lecture, which is on platelet-rich plasma for the thin endometrium. Let's ask the recap from the chair of the Education Committee, Dr. Claire Boothroyd.
Thanks, Joy. I think the summary evidence is that there is one small randomized controlled trial, and there is some animal data suggesting benefit of the intrauterine administration of PRP in women with a thin endometrium, but there is no evidence on live births and adverse outcomes. The protocol is uncertain, and there is quite widespread use of PRP from what I can gather, and multiple administrations are often used. The mechanism of action appears to be improvement of endometrial thickness, but it may be by other mechanisms, and it does appear that this is biologically plausible, but that may come up in our discussion. I think there needs to be further studies on this use of PRP for the thin endometrium, and they need to report live birth and obstetric outcomes, and its use should really only be occurring, in my opinion, in ethically approved research settings.
Okay, thank you, Claire. So now that we're done with our recap, we can now open the floor for questions as regards to any of these topics that were covered. I'd like to remind again the audience that they can send in their questions through the chat box, or better, to the Q&A box, so that we could ask our experts directly. I'd like to shoot the first few questions while we're waiting for the questions coming from the participants. So, Louise, let's just go back to your topic, which is supposed to be our introductory talk. When do you really consider that an endometrium is considered thin, and how should you be able to diagnose thin endometrium?
I think most people would be wanting to have an endometrium over 8 millimeters if possible. So I think once it becomes under 8 millimeters, we would be either, if we're in, say, an artificial cycle, you might want to give estrogen a little bit longer, or see if you could get the endometrium a bit thicker before considering starting progesterone to do the embryo transfer. The studies have used different cutoffs, and many use, the most common is actually to use less than 7. So the research side of it is based on 7 for most studies. The 95th percentile is in fact 8. So there's a lot of controversy as to what is a thin endometrium and what isn't. But what's very clear is that the pregnancy rates increase in a more continuous fashion. And if you have an endometrium that's 8 versus 9, the likelihood of pregnancy goes up, and 9 versus 10 and 10 versus 11. So there's not really, I'm not sure a cutoff is the best way to look at it. And it's just probably, if you can get it as thick as it possibly can be for that patient, that would be the ideal. For some women, however, you know, at 7 millimeters, you can put an embryo back and they conceive. So again, it's something I'd be very interested on the panel's decision making. When you have someone which repetitively you can't get an endometrium beyond 6 or 7 millimeters, at what point do you decide to transfer the embryo, or to come back with a different treatment, or to decide that you can't transfer an embryo? Because if an endometrium under 8 millimeters, there's still a 23% chance of having a pregnancy. So, you know, you can transfer embryos with thin endometrium and have a pregnancy outcome that's quite good. And 63% will get to a live birth. So I don't know that it's a great decision-making node for deciding whether to transfer the embryo or not. The question is, how can you get it higher if it's thin? And that's very controversial as well. And then at the end of the day, if someone does have a thin endometrium, you really can't predict whether they'll get pregnant or not. And you can't be too pessimistic either. So I would be interested in what the other panelists felt.
Yeah, so it seems that increasing the endometrial thickness from 7 to higher thickness levels would improve pregnancy rates. So we're trying to find out what improvement did we do aside from thickness to explain that thing that's happening. Any ideas from the group? I saw...
I would just like to make a comment is when we are looking at thin endometrium, and many times we have a very long cavity. In these group of patients, it's good to estimate the endometrial volume. And many a times, even with a thin endometrium, if we have a good volume of more than 2 cubic centimeters, I have seen that pregnancies happen. So probably we could add this in women who have a thin endometrium.
Okay, so it's all not only thickness or the thickness at one point, but the overall volume that may contribute to success. Any other ideas on what could have contributed? Yes, Christos, please.
Particularly in cases of persistent thin lining, and by that I mean usually around 6 millimeters, one thing that I have noticed that makes a difference when we decide to go ahead is the actual, the actual appearance of the lining. Whether we do have that nice trilaminar pattern, that can be sometimes a good, a good prognostic indicator. Whereas when the lining seems to be irregular and on top of that is not getting thick, then to me that's a very, that's a very bad sign. Whereas when you have very clear margins and you have clear 3 lines, in my books, that's something that would make me potentially more keen to transfer an embryo in that lining.
So other characteristics are important to say that this particular thickness would work or it would not work. I would now like to ask from a basic
Can I just
point of view. Yes, we're getting to you. We need your input, Gendie. I'm sure there would be some input from the scientific point of view on how a thin does not work and a thicker endometrium would work. Please.
Oh, I think we also need to be looking at quality, and that's probably what Christos was saying, that you might have a thin endometrium of good quality, of all of the right balance of vascular maturity, of glandular maturity, of the different leukocytes that are needed, that can sustain a pregnancy all the way to a live birth. Because what's very clear that's coming out is, if you're reporting a clinical pregnancy, things are looking okay. But when you're reporting live births, things aren't looking as good. And I think that comes down to much more probably about the quality of the endometrium. So you could actually have a thick endometrium that's really poor quality, and that's not going to sustain a pregnancy either, versus a thin endometrium that's of good quality that will sustain one. So we need to also be looking at biomarkers of quality as well as quantity.
Taking your cue from other biomarkers of quality, aside from the thickness of the lining, you started talking about vasculature. Yes. And we were talking about, in some studies, they would talk about the need to do Doppler studies. Can anybody say anything about using Doppler ultrasound to try to say that this thin endometrium or borderline endometrium would probably be a good endometrium, or even though it is thin? Anybody who has any experience?
So basically, if we see that the endometrial flow is at least subendometrial or even reaching, because they say that the best implantation rates are seen when it reaches the zone 4, that is right in the center. But in my experience, I've seen if you have little blood flow in the periphery and your RA is low, basically, even if the endometrium is about 5 or 6 millimeters, sometimes can result in pregnancies, because in my experience, I have had about a couple of pregnancies with endometrial thickness of 5.1, one was at 5.8 and one was at about 6.4, wherein we look, because this patient, we had postponed her endometrial transfer almost for 2 or 3 cycles because of the thin endometrium, and then we looked at the volume, which was about 2.8, and we looked at the Doppler, and then we thought that it was a triple line, and we did the embryo transfer. And I think in these difficult patients, wherein we have used most of the treatments and we have not got any advantage of increase in the endometrial thickness, then including Doppler in your armamentarium for assessing the endometrium is a good option.
Very good. So beyond just the thin or the thickness, then you have quality, and among them, vasculature is something that may help us detect if the thin endometrium is going to be harmful or not. I was going yes, please.
Can I come in? I think there have been some good studies on subendometrial blood flow around the time of implantation, especially in thin endometrium, to see whether you would add additional information. But my understanding is that the study showed there's no need, no benefit in assessing subendometrial blood flow in the thin endometrium. It doesn't help. And I think there are good studies from my colleague, Professor Anderson in Hong Kong, and also meta-analysis. So I don't routinely measure the Doppler blood flow of the subendometrial level now.
Okay. Thank you, TC. Another thing that probably should be brought up now that we're talking about quality is the issue of gene expression, and it's always been there. They're talking about the various genes now that are present in the window of implantation. Does anybody have any input regarding any study on gene expression in thin endometrium versus thick endometrium? There was one Japanese study that I saw quite a while back. I wonder if you came across that. Is anybody familiar with that? The study is by Meikawa of Japan, 2017, where they found a different set of genes that were expressed in a thin endometrium versus a thick or a normal endometrium. So that's another thing that we should probably need to study on. We need more studies about those. Okay. Yes, please, Christos.
Just on the topic of gene expression in endometrium, I think it's a fascinating field of research, but I think we're far from actually being able to extract any clinically useful information. We're still not very certain what genomic signature does the implantation window have, and sometimes that can alter. And we have not yet, we have not developed the tools that allow us. We do know that the gene expression changes in the same woman during a menstrual cycle, during the different phases of the menstrual cycle. And we do know that sometimes the gene expression profile might not be a great predictor of pregnancy. For example, I know studies that have very convincingly shown that when you have an HRT preparation of the endometrium compared to a naturally prepared endometrium for an FET cycle, the gene expression profiles are tremendously different. But having said that, most of the randomized trials that have been performed, like the Antarctica, have failed to show any difference in live birth rates. So I remain a bit skeptical. I think it's a very significant tool, and I think we need to keep exploring. But at this point in time, I refrain from making any judgments or any conclusions on the basis of gene expression studies.
Thank you, Christos. So the message there is gene expression studies on the window of implantation have not yet been fully established. So making claims about the different set of genes in thin endometrium is a bit difficult to make conclusions on right now. We have a question from the audience, from the participants, and it's a case, so this will take a bit of time, but let's entertain it. It's the first question here. I have a patient with severe Astroman Syndrome, so you know who this question is going to. She had a DNC previously, and since then had irregular menses and amenorrhea subsequently. She did not respond to any medical treatment to induce menses, including progesterone. She had 2 hysteroscopies so far within 6 months, and now is on sildenafil, vitamin E, L-arginine, and estrogen, 12 milligrams, and almost for 6 weeks. And after discontinuing treatment and progesterone challenge, still no menses. Do I need to wait further for this? How do I proceed? Can I start IVF? What protocol do you suggest? So it covers all you guys already. So let's start with the Astroman Syndrome, which should probably be covered by Prof. T.Chiu Li.
Thank you, Joy. Thank you for the very interesting case. I think the issue is that she has been diagnosed with severe Astroman Syndrome, and she had treatment, but still she has not had a period. The question then is, why is it that after treatment she still have not had a period? Now we know that with severe Astroman Syndrome, recurrence is a common problem. About 50% of cases would recur, the adhesion will recur after treatment. So we need to know whether the Astroman Syndrome had indeed recurred, or whether the treatment was considered successful and now she got a normal cavity. Assuming that the treatment has been successful, but the recurrence has occurred, then we need to discuss further treatment and see whether she would benefit from a further surgical attempt, and then with all the adjuvant available to prevent adhesion reformation, including early second node, using balloon therapy regularly. On the other hand, it is possible that the cavity might now be normal, but she has a concomitant endocrine pathology. In other words, she might not be ovulatory. And in that case, we need to think about using regular cyclical estrogen and progesterone to induce withdrawal bleed. So we need this further investigation into the outcome of the surgery. Now, as far as whether we could start IVF or not, it is possible to retrieve oocytes and create embryo, even though the woman has not had a successful treatment with Astroman syndrome, because you might not want to replace the embryo bag, or you might want to freeze the embryo for the time being. But clearly, before you replace the embryo bag, you need to ensure that you've got a normal endometrium with a satisfactory thickness and a reasonable amount of secretion in the endometrium. So I think hopefully we can induce regular menstruation before we put the embryo back.
Okay, thank you, TC. Louise, you have something to add?
I'd actually like to ask TC Li, at what point do you decide you need surrogacy for someone with a very, very severe Asherman's?
Well, I think if you cannot create a normal endometrium or period, in other words, the endometrial cavity is still very scarred and it's not possible to recreate a normal endometrial cavity, or in some borderline cases and in whom you think it is rather severe, endometrium is quite thin, let's say down to 5 or 6, she has period, but after you try to replace 1 or 2 embryos and yet it's not pregnant, then I think there will be a point where we have to seriously think about surrogacy. So I think if the chance is very low, then you would discuss surrogacy. But I have patients, I do have quite a few patients where the endometrium is only 5 or 6. And when you put back embryos, there are times that they can conceive. We know from the data that you presented, and also from Gendie presented, below 7, it is still possible, although the chance is reduced. So in those cases, it's always worth trying. Now, the way I look at it is, particularly in Astroman syndrome, one side, maybe the right side, is very badly scarred. The left side may be normal. So when you put back the embryo, if the embryo is clever enough to go to the correct side and implant in there, there will be a chance. The overall chance is reduced, but there is some chance. So in those, what I call gray areas, it's always worth trying to put back embryo once or twice, or sometimes up to 3 times, before seriously thinking about surrogacy. So it's worth a try. We know it's not, the chance is not 0. But clearly, before we do that, we need to try to improve the endometrium thickness function as much as we can. There's one other point that I like to make about putting embryo back. In a thin endometrium, if you worry about the embryo, whether it can support implantation, it's often helpful to take a little biopsy, small amount, around the time of expected implantation, especially if you say this cycle is not good enough, to see if there's any secretory changes. If there's no secretory changes, no hope, because the endometrium is all grotty. There's no secretion. How can the endometrium support implantation? But if there is, it is thin, but normal thin. In other words, it is thin, but it has secretion, a reasonable amount of secretion. Then I think it's worth trying it out. So assessing the endometrium, like what Gendie said, be a bit more scientific. Thin could be normal. Thin could be reasonably normal, but thin could be very bad, could be no chance. So we need to investigate not just the ultrasound, but also Christos mentioned the morphology, whether they got triple line pattern. From time to time, I see thinnish endometrium, but good morphology. Those cases actually have a good chance. So other than the thickness, morphology, histology, and other form of the assessment would be worthwhile contemplating before giving up.
Yeah, Christos called out a while ago. Please, Christos.
Yeah, no, I fully agree with TC Li, with Professor Li, and I would like to just to add the fact that, and I think he very, very nicely alluded to that in cases where we have Astroman syndrome, probably what constitutes a thin endometrium in terms of if we're using a cutoff changes, we have to be more lenient in these cases, particularly in very severe Astroman syndrome, expecting even in the best of hands, even in Prof. Li's hands, the lining to all of a sudden start growing to 9 or 10 millimeters. It would be great, but in most cases it doesn't work like that. So in these situations, we have to be satisfied with a thinner endometrium as long as it presents other characteristics that seem to essentially tick the box for a transfer to happen.
Madhuri?
Yeah. Basically, we also need to look at the extent of adhesions, because many a times, even after doing adhesiolysis, and when we see we give high doses of estrogen, and when we repeat the hysteroscopy after 3 months, we still find that there are adhesions. So in these patients, basically, I mean, it's just not the endometrial thickness, because the cavity also needs to be normal for the implantation to happen. So I think we need to give, we have to give importance to both, whether the adhesions have resolved with the treatment, the surgical treatment we have offered, and the endometrial thickness, and all the other factors what Professor Li did say. So I think looking at the adhesions, whether they're reformed or not, also is very important.
Okay, thank you. Because we're still talking about the same case and we can cover other areas which you covered in your talks, we might as well talk about the use of stem cells, which is being advocated for severe Astroman syndrome, and the other innovative treatments that you can do for these particular patients. Anybody, please? Does anybody have anything, any experience or any data that they have where
Yeah,
stem
I
cells
can talk on stem cells, because in India we've had a few centers for using stem cells in patients who are having thin endometrium, and there are a few of them where they've used it only even in patients who have Astroman syndrome. So what here they do is they use the bone marrow stem cells. They have been used, and what they have found that they inject it subendometrially, and in patients with thin endometrium, they have found that it really has helped them. And I think as far as I can collect, it's only one patient who had Astroman syndrome, wherein they used the stem cells and they were able to achieve a pregnancy, whereas in all the other cases, they've not achieved. There was another center in Maharashtra where they used endometrial stem cells, and they have reported that the endometrial thickness has increased, but I'm not aware of if any pregnancies have been established.
Okay. What about other things that they can do in case the endometrium that still get thicker? Are there any other strategies that we can propose to this patient? I think
Probably we can try sildenafil, because I think that has all the drugs which I had, the medical treatments which I mentioned in my talk. I think out of that, sildenafil is the most promising, and probably it can also be easily be used because the evidence, though the evidence is contradictory, but there are many studies which have shown it to be effective.
Okay. There's another question.
Can I just ask,
Go ahead, Louise.
can I just ask, I just want to ask Gendie, just in terms of the pathophysiology, there's a bit of a balance of too much oxygen delivery and not enough. Could you give us a bit of information on that?
So there was a study a few years ago from Graham Burton and Eric Giagnò that was miscarriage, and they looked at both spontaneous and recurrent pregnancy loss, but at the time of pregnancy loss, and every single placenta that they looked at had evidence of oxidative stress. And then when they did, trying to remember this, and essentially when they did Doppler studies, there was an increase in blood flow to the placenta, causing oxidative stress, like just far too much oxidative stress that the placenta at that stage, very early stage, so pre-10 weeks of gestation, is not equipped to handle. And they put this down to a lack of plugging of the spiral arteries and over opening of them, and then this burst of maternal blood flow into the placenta and affecting it. And this was both in recurrent miscarriage and spontaneous. And we would, and I think most people that have worked on recurrent miscarriage would say that this is an endometrial problem, not a placental problem. So it was interesting to us that there was this underlying concept, and then work we did a few years ago did show that in a subset of women with recurrent pregnancy loss and recurrent implantation failure, there was an increase in the maturation of the endometrial vasculature. And so these are overly muscularized vessels that have a much higher rate of flow, and so therefore could be negatively impacting any implantation. Embryos like to implant in around 1% of oxygen. Their normoxia is what any other tissue would say is hypoxic. So actually, so my gut feeling is if you are overly increasing the oxygen environment, that embryo is not going to be happy. They like 1 to 2% of oxygen. So I'm not convinced on the giving too much oxygen into their environment is not going to be good. You might get implantation, but you're not going to get good placental embryo development.
Okay, Claire is raising her hand, and I think you can also, aside from what you're going to say, you might also like to include the benefit of PRP in this particular case.
Yeah, sure. Gendie, so that actually is very interesting. So am I to interpret that you would think that things like nitric oxide would actually not be biologically plausible?
Well, there's evidence that that nitric oxide can help nitric oxide donors in severe hypoxic environments. But yeah, my gut is too much oxygen isn't good. You need to get a balance.
Okay, can I just take you one step further?
Yeah.
Is from an endometrial scientist's perspective, do you think PRP is biologically plausible? I was very, very intrigued when I think it was Pete Robinson? Told me that he really didn't think that endometrial scratching was biologically plausible as a mechanism. And of course, time has taught us that, even though the meta-analyses led us astray for quite a few years. But I'd really like your opinion on whether you think PRP is biologically plausible. The injection into the endometrial cavity of a whole lot of platelet-derived growth factors, plus or minus whatever else is in that mix, is that really likely to make a difference to endometrial proliferation and vascular change?
I think it's probably more likely to, because it is a whole soup of factors. I think if we try and boil it down to one factor, there is so much redundancy in the processes required for endometrial development and maturation that I think if we try and become too reductionist and we try and boil it down to one factor, we're each going to have our favorite. For me at the moment, it's TGF-beta. I think it's fabulous, but I don't think it's not going to be the be all and end all of endometrial maturation. So I think actually putting in perhaps a more biologically relevant soup, which is essentially what the PRP is, has more logic than one factor alone. And I think anything that can target what we really want to be doing, I think, is targeting the basales and targeting the stem cell niches in the basales, and getting, an adequate regeneration of the functionalis, that we might have long-term effects for regeneration of the functionalis, not just a one-term hit on the functionalis and getting it thicker in that one cycle. If we can really think about this logically and start trying to target the basales, then it might have a much more long-term benefit for those women. Excellent. And the studies need to be done, but I think actually a soup is better than a single factor.
Thank you. Yes.
So for want of a scientific word.
Yeah.
Sorry, a milieu of factors.
Yes.
Okay. There is another question at the Q&A box. A question from Dr. Susanto from Indonesia. What is your opinion about what is the importance of endometrial thickness in the success rate in IUI? Can anyone answer that? How similar is it in the perspective of IUI compared to IVF? Yes, Madhuri.
Yeah. So I think in my talk also I had mentioned, because when I did the literature search on various medical therapies, I found only one paper which was there in Human Reproduction in 2017. I think it was by Weiss and et al. And what they said, that there is no correlation between endometrial thickness and the pregnancy rates in an IUI pregnancy, and therefore you should not defer an IUI even if the thickness is less. That's what that paper concluded.
Okay. Any other additional comments? If not, we'll go to the other questions among us. May I ask again, Professor Gendie, is there anything that we are doing, the clinicians? I know you're looking from a scientific point of view. So for us clinicians, do you think there's anything that we're doing wrong which is contributing to the development of thin endometria? Like, for instance, all the procedures that we do. Of course, we know that DNC might contribute, but what about the long-term use of clomiphene citrate, which is known to cause thin endometria? Do you think all these contribute to the development of thin endometria?
I mean, there is some evidence that long-term oral contraceptive use, so 10 plus years of continuous use, that there can be a prolonged effect of that even when a woman comes off. I don't know, the studies haven't been done on whether or not continued clomiphene citrate cycles will have a long-term effect. We'd need to be looking at whether or not it's acting just at the functionalis or having long-term effects on the basalis. But quite frankly, the evidence isn't there because the studies haven't been done. Because once a woman gets pregnant, we don't really care what her endometrium is looking like until the next time she tries to get pregnant.
Okay, thank you.
Can I just in my clinical experience, I find quite a lot of people either have had a baby with retained placenta and trauma and then breastfeed for a long time in a very hypoestrogenic, or people with PCOS will have a DNC and then not ovulate and not have a regenerative proliferative phase of that endometrium. And I just feel that there probably is a need for more research about, post-trauma, how to prevent a very hypoestrogenic environment at that point. But I'd be interested in what other people feel.
Look at Louise, I absolutely concur. I mean, Astroman Syndrome is rare, and we do lots of curettages, and endometrial injury is common. And it seems to be this setting of inadequate estrogen levels for repair, and I would be very interested to see what Gendie thinks about that being, again, fitting with the basic science, because it's certainly a clinical impression that these women who are anovulatory, particularly the centrally based menstrual disturbance, who truly are estrogen deficient, if they have an endometrial assault, whatever it is, it seems to be adverse and put them at increased risk of endometrial scarring or denudation, because they're really sort of, as TC has articulated, there may be intracavity adhesions, but equally it can be a denudation back to the basalis. So Gendie, look, what do you think about that?
I think you're absolutely right, and I think we need to really understand and how injury plus, because as you say, lots of women have DNCs and have absolutely no problems, and so it seems to me that there is it's a 2 or 3 hit compound problem that, but the research just isn't there. I think you probably all have anecdotal feelings and stories, and you will have much more of an idea just because of your daily practices of how women react. But it's actually very hard to put that together into an evidence-based package.
So no mouse studies.
As far as I could find, no mouse studies, but I don't. I'm a human person. I do not do mice. Mice don't menstruate. They don't get pregnant in the same way. I see no relevance in a mouse.
Can I ask about endometritis? Is it a cause of thin endometrium?
I couldn't find anything on that when I saw your question, but there is on tuberculosis. So there is some. So there is evidence of infection impacting the endometrium, and what I would consider is that you're having to repurpose your endometrial leukocyte population. So your UNK cells, your macrophages, your T cells can no longer do their tissue remodeling jobs, and the jobs that they absolutely have to do for the maintenance and the establishment of a good endometrium and then a good decidua and pregnancy, that if there's an infection there, they're not doing those tissue remodeling jobs because they're off there being fighters, and the endometrium suffers as the response to that. So I think endometriosis, probably, but I couldn't find any evidence. You probably all have more anecdotal evidence than I do.
Yeah. Christos wanted to say something about endometritis also, but I think we should also let TC say something. When the magic word is endometritis, you have to include TC in the conversation. Christos, please.
Just very briefly to say that in my view and based on my understanding of the literature and my small personal experience, endometritis is more linked to causing thin endometrium when combined with trauma and hypoestrogenemia, rather than endometritis being the cause, rather than endometritis not allowing an endometrium to grow, if that makes sense. And the reason why I say that, because in our recurrent implantation failure clinic, we have very frequently women that have fantastic endometrial thickness but fail to get pregnant. And then when we do the hysteroscopies or the endometrial biopsies, they do satisfy and tick all the boxes for endometritis. And they're not commonly the main patients that we see thin linings. So I do think that in the causal pathway, endometritis in a way is what might add to the damage that the basalis might suffer and then lead long-term to thin endometrium.
TC first and then Madhuri.
Yes, I agree that with Claire, there's a very interesting question, whether endometritis is a cause of thin endometrium and how often does it cause a thin endometrium. From my understanding, there is really no good data on it, Claire. I think the study needs to be done so that we can understand more about the relationship between a thin endometrium and chronic endometritis. This is important because chronic endometritis can potentially be treated with a couple of weeks of antibiotic therapy. And it's simple. It doesn't need a hysteroscopy, it doesn't need surgery, and it would improve the estrogen response, the impact of the endometrial response to the estrogen. So I think it's an area very interesting. We need to study it.
Yes, Madhuri.
In India, wherein we have the tuberculosis is still endemic, it's one of the causes of thin endometrium. And I would also like to add on the hormones and the endometrial thickness. And if we extrapolate cases from a fertility preservation for endometrial malignancy, where we are using progesterone, either orally or we put in a Mirena. And when we do an IVF in these patients, what I feel that the endometrium is thin. So many a times women do use Mirena, and then once they remove it and they want to go in for a pregnancy. So I think this high dose of progesterone can also have an effect on the endometrial thickness.
Thank you. Do you believe we're past our deadline already and we still haven't covered a lot? I I already saw this at the start, Claire. We need 2 hours, not just 1 hour, but we have to go. And so I think we're devoting the last 5 or 10 minutes of our time to giving each of you a take-home message regarding your talk so that the audience can, again, get a grasp after all our discussion. Let's ask each of you to give a key message, take-home message. Please, let's start with Louise.
I think a key message is that it is worth measuring the endometrium and trying to improve the thickness if it's under 8 millimeters. I don't think, still, I wouldn't be so pessimistic to say that if we transferred an embryo, particularly if it looked to be of high quality with a trilaminar appearance, I think it's still worth doing. And then I think there are other aspects that if you perpetually have a thinner endometrium, you do have to look at surgeries and investigations to work out why and how to target your therapy.
Thank you, Louise. Gendie?
I guess my take home is research, and quality. So that this idea that thin but good quality probably has is good or better chance than thick of poor quality. So look at your quality assessments as well as just the thickness, and where you can, talk to your scientists and do research on why this is bad or what is causing it, because once we know what causes, what the fundamental underlying causes are, then we can treat.
Thank you, Gendie.
So that's my take home.
Thank you, Gendie. TC?
Yes, I agree with the view that a thin endometrium could still be normal. But I think clinically, when we are faced with a thin endometrium, prior to putting back the embryo, we need to ask ourselves a question. Should I or should I not put the embryo back? The key to that is, can I improve the endometrium further? Is the underlying reason for the thin endometrium? So it is a time where we start to think. So in order to find out whether there is any underlying reason, we need to look at what sort of tool we have. A 2D ultrasound, a 3D ultrasound is important to look at for more subtle problems like irregularity, small amount of fluid, and also ask the patient about the history. Has she had repeated surgery? Has she had repeated implantation failure? Now, if we think there is a specific underlying reason in the endometrium that could be treated with accepted modality like surgery, then we should investigate further, for example, by hysteroscopy. Now, hysteroscopy is very simple. You can do it in office procedure, no anesthetic, no pain control. Have a look. I think it's worth doing that because while we say a thin endometrium still have a chance, but we know its chance is only down to 50% of what it would be. I think if we put back embryo and then we waste the embryo, it's also not very good for the patient. So I think my message is start to think about whether we can improve the endometrium further. Should we investigate further by more tests, endometrial testing, histology, or other tests, or hysteroscopy?
Thank you, TC. Christos?
Thank you. It has been a very exciting panel and forum to be a part of. So I agree with everything that has been said. I would also particularly like to emphasize what Gendie said about the fact that we need to do more research on this. But for those that clinically want some answers, and again, relevant to the topic that I covered, I would like to always call for looking into the basics first. And in some cases, just utilizing larger doses of estrogen or for an extended period of time, that alone might be enough in some cases where we might have some type of estrogen resistance before resorting to exotic, unproven, and potentially harmful other treatments. So that would be my message.
Thank you, Christos. And when we're talking about innovative methods, we go to Madhuri. So what would be your take-home message, Madhuri?
We know that the efficacy of most of the treatment modalities that we've been using to improve the endometrial thickness have been controversial. So basically, we need to identify the specific subgroup of patients where each of this treatment probably would be helpful. And I think we need to have a lot of evidence to come for most of the drugs which I have enumerated in my talk. Thank you.
Thank you, Madhuri. And finally, on PRP, Claire.
I'm also going to talk about PRP. I was going to say that this session has been absolutely fascinating, and I think my take-home message is that the thin endometrium is actually a heterogeneous collection of conditions, and we do need to talk more about it and have more discussion and more cross-fertilization of different viewpoints and reviews of the literature. I guess as a board member and a chair of the education committee, my vision here is two things that I can see here. One is that Gab might, if we can get ourselves galvanized as a panel, Gab will be very pleased to see a review article on all of the stuff that we've pulled here in fertility and reproduction, and I see that that's a possibility. And I also think that we should, in Aspire, and the board is going to be making some decisions along these lines, is think of the huge patient pool that we have potentially in the Asia Pacific region for the recruitment of trials for a condition which can be catastrophic for our patients, but is not particularly common. And so Aspire is well positioned to actually start to answer some of the questions by recruitment to trials of the thin endometrium.
Thank you, Claire. So it's been a very, very interesting morning talking about thin endometrium, which is one of the most challenging problems in ART. Today, we review the various issues in managing thin endometrium, the diagnosis, the pathogenesis, various treatment strategies. And I'm not sure if we answered more questions as we have more questions that we have created with what I'd like to thank our excellent speakers who have worked hard to try and explain these issues. Associate Professor Hall, Professor Lash, Professor Li, Dr. Venetis, Dr. Patil, and Dr. Boothroyd. Indeed, this was a very interesting and enjoyable Q&A session on the thin endometrium. And with that, I'd like to close this Q&A session. We hope you learned from this and also invite you to the next Aspire webinars. I'm Dr. Novero from the Philippines, and I'd like to thank you for participating. Thank you and goodbye.